Good morning, everyone. It's my pleasure to be joining you for this ISEE meeting virtually. And I'm happy to be able to share with you some thoughts on urban living and health equity and some opportunities that this presents for environmental health research. I think it's terrific that ISEE is really broadening the way in which it thinks about the environment because it's so critical to our world today. So what I'm going to do is briefly talk about 6 reasons why we should be focusing on urban environments. Perhaps some of you don't need convincing, but I think it's important to highlight that. Folded into that, I'll be highlighting what I see as some opportunities for environmental health research. And then at the end, share with you a project that we have where we are trying to integrate some of these ideas on the impact of urban environments and health, the SaludVal project, Salud Urbana en América Latina, Urban Health in Latin America. So the first reason is, will be no surprise to any of you, why we should focus on urban living. And it is that the future of humanity is largely in cities. And we have seen urbanization rates increase very quickly over time, especially in areas like Africa and Asia that were not very urban until relatively recently. And it's important to remember that this growth in urbanization is not only growth of very, very big cities, the big metropolis, but it's also a very large number of smaller cities, both in the developed and in the lower and middle, developed world and in lower and middle income countries. So these so-called emerging cities provide a lot of opportunity for us to think creatively about how these cities can be designed and managed so that their environments do promote health. The second reason why we should focus on urban environments and health is because the health implications of city living are actually variable and malleable and therefore amenable to policy. If you think about what the correlates of city living are, certainly perhaps the cardinal feature of city living is high population density. And this comes with diversity in race, ethnicity, national origin, and social class, concentration of economic activity, more intense and perhaps qualitatively different social interactions, innovation and creativity, which is also a hallmark of cities and what attracts many of us to cities. Now, these features of city living have possible health implications, and some of those health implications could be negative. So, for example, adverse environmental exposures are often concentrated and magnified in cities: air pollution, other industrial exposures, poor housing, heat. Physical environments of cities affects behaviors, and sometimes those effects are not positive. Urban design can promote sedentarism. Cities are often characterized by increased availability and access to processed foods. Advertising of unhealthy products can be concentrated in cities. Overcrowding and enhanced transmission of infectious diseases, something that is very much front of our minds today. Limited access to services, precisely because of the concentration of population, limited access to housing, water and sanitation, health and social services. And sometimes cities are characterized by social stressors related to conflict, violence, discrimination, etc. But cities can also have positive impacts on health. City living can have positive impacts on health. Certainly, cities provide income and work benefits. This is why people move to cities. And those have health implications, as we know. There's a potential for better access to services as a result of proximity and greater availability. Cities can be places of very positive social interactions, cohesion, support, advocacy, all of which can be beneficial to health. The creativity and social interactions that characterizes cities can be health enhancing in many ways. Urban policies can promote health, and because of the concentration of people in cities, urban policies can affect large numbers of people simultaneously. Now, what does the data show regarding the effect of city living on health? Well, in fact, it's highly variable. And I'm just going to show you one quick example of prevalence of obesity. On the left, you have 2 panels that describe how obesity changes from more urban areas on the left to less urban areas on the right in the United States. And you can see how obesity increases as urbanization decreases. However, the panel on the right shows for different countries of the world, and many of these are low and middle income countries that are shown here, the prevalence of obesity is actually often higher in urban than in rural areas. So this single example, and there are other examples as well, shows that in fact, the effects of city living on our health are highly context dependent, which is important because it means that we can do something to generate positive health effects. And in addition, all cities are not the same. This is an example of avoidable mortality across European cities, so all cities in higher income countries. These are estimates for neighborhoods within cities, and you can see a box plot showing the distribution for each city. And I just want to highlight here how there's a lot of variation across cities, but there's also variation within cities. Another example, I always like this slide of firearm homicides per 100,000 in the United States, showing how city differences across the United States are comparable to differences across the world. So large heterogeneity across cities. Another example, very interesting paper a few years ago in JAMA, showing life expectancy by income in different US cities. And what I want to highlight here is how if you are low income, towards the left in the plots, your life expectancy varies significantly depending on what city you live in. And so why is that? These are important questions. So the consequences of city living are variable and malleable. Third reason, the health consequences of city living are not the same for all. Cities are characterized by large social and health inequalities. These are just two figures showing inequality in income in cities. On the top left, the inequality in the 50 largest US cities and in the whole United States. So you see there's greater inequality, income inequality in the larger cities. And on the bottom right, so maybe a little bit small, but this plots the urban Gini coefficient versus the rural Gini coefficient on the y-axis for a number of countries. And what you can see here is that the urban Gini coefficients are significantly higher than the rural Gini coefficients. So large inequalities within cities, and these inequalities are translated into health inequalities, which are manifested spatially. You may have seen these figures generated by the Robert Johnson Foundation showing very large life expectancies, even within short distances within cities. And of course, these patterns are generated, these within city differences, inequities are generated by a number of interrelated processes. So here on the left, residential segregation by race, by socioeconomic position, creates inequities across areas and resource distributions. These factors reinforce each other over time and create differences in the physical and social environments of neighborhoods within cities, which then, of course, reinforce each other as well. And this translates into behavioral and stress mediators that, again, reinforce each other, and this ultimately affects health. So there's really a dynamic process, something that I'll return to later, that has generated these within city differences linked to inequities. The fourth reason why we should focus on urban environments is because health in cities is driven by factors at multiple levels and therefore provide opportunities for multi-level intervention. So below here on the slide, you have a figure from an urban planning book highlighting the impact of these different levels. This is a slightly more elaborate conceptual model, actually a model that we developed for the Salrubal study. And I'm not going to go into the details, but really it places cities sort of within global trends, but then in the middle really focuses on the impact of urban policies and interventions on the health sector, but also outside the health sector. And then the specific mechanisms, which as you can see, often involve environmental factors through which these urban policies affect health in cities. And on the right, the outcomes. I just want to highlight that this is a theme that I'll return to, that it's important to think about health and environmental sustainability as outcomes that reinforce each other. So in the health field, we have a tendency to focus on health, of course, but I think broadening our perspective so that we are thinking about health and the environment as interrelated and policies that promote health, promoting also environmental sustainability and vice versa is really critically important for our world today. The fifth reason why we should focus our research efforts on cities is that cities are acting, but we actually know very little about the effects of urban policies on health in cities or on health equity. As I noted earlier, there are many different policies that cities are implementing, and yet there are very few rigorous evaluations of the health and environmental impacts of these policies. This is something I'll return to later. Of course, this is hard to do methodologically. We often have to rely on observational data, natural experiments. Occasionally we can design studies specifically for this purpose, but it's really a very important area. Cities, of course, can be thought of as systems, and in fact, over history, there's a long tradition of thinking of cities as systems. On the left, you have a picture of a book by Jay Forrester, one of the sort of first forefathers of urban dynamics, his book on urban dynamics from the late 60s, and on the right, a more recent book on the new science of cities by Mike Batty. So a long tradition of thinking of cities as systems. And why is this important? Well, it's important because at the core of factors that influence urban health and sustainability and environmental sustainability are what we call dynamic relations. And dynamic relations emerge from feedbacks that are happening between factors, and also from something called dependencies. So this is the idea that one person influences each other. People influence each other, or a neighborhood can influence a neighborhood next to it. And these feedbacks and dependencies generate patterns, including nonlinear effects, effects distant in space and time, make the effects of certain factors depending on the state of other factors in the system. So the role of context in modifying the effects of certain factors, and also may create unanticipated effects. So this is highly abstract. Let me give you a bit of a more concrete example of what I'm talking about. So let's imagine we are thinking about the impact that a new rapid transit system could have on health in a city. So, we might hypothesize the rapid transit system reduces automobile traffic, increases walking, promotes mixed land use, and these things we know are related to health, to injuries, less injuries with less automobile traffic, lower air pollution, less chronic disease. Walking may also promote physical activity. Mixed use, on the other hand, perhaps it might have an adverse effect. There may be situations where it's related to increases in violence, not always, but perhaps. This may have an adverse effect on walking, so you start to see some feedback loops emerging here. Certainly walking may promote mixed land use, mixed land use may promote more walking. Walking in the context of high air pollution may actually be bad for health because you're exposed to more air pollution and more traffic. Higher air pollution may may disincentivize people from walking. As we've been talking a lot about recently, rapid transit potentially, if it increases the physical proximity of people, can promote infectious disease transmission. So the bottom line here is that there are multiple pathways involved in how rapid transit could affect health, and that the ultimate effects of rapid transit on health are going to be conditional on the state of other factors in the system. And that means that it may have a plausible range of effects on different outcomes, and that these effects may differ depending on the conditions of other factors. And thinking about the process systemically may also help us identify new leverage points. So perhaps we have to intervene simultaneously on rapid transit and simultaneously on other factors to prevent any adverse effects of rapid transit. So it really highlights why we should think systemically when we think about urban environments. And last but not least, the sixth reason I want to talk about why we should focus on urban health and urban environments is because, as I alluded to earlier, urban health and environmental sustainability are really linked and reinforcing. So let's sort of think about, hypothetically, the consequences of urbanization. This is schematic, but let's imagine a future of high urbanization. One option is that it's associated with more sprawl, more energy consumption, more car dependence, more processed foods. Unfortunately, a direction that we're going in many areas. This leads to the growth of urban footprints, adverse impact on biodiversity, biomass, croplands, higher air pollution and greenhouse gas emissions, less physical activity, more consumption of meats, less fruits and vegetables, both of these with adverse health impacts. So this is one pathway, and potentially social consequences related to isolation, violence, and mental health. Long commutes, for example, have been linked to adverse mental health. So here we see a way in which urbanization could evolve to have adverse health and environmental consequences. There's also another option where we have more compact development, energy efficiency, active transportation, sustainable food systems. In this case, we might see less growth of urban footprints and reduced impact on biodiversity, biomass, and croplands, reductions in air pollution and greenhouse gas emissions, more physical activity, healthier diets, and perhaps a more inclusive and equitable city. So in both of these scenarios, you can see how health and the environment are entwined. And in fact, certain policies can promote good health and at the same time, good environmental sustainability, and other policies may have the opposite effect. So these are the 6 reasons future of humanity lies in cities. Consequences of city living are variable and malleable. Cities are home to large social and health inequities. Multi-level determinants provide opportunities for intervention. Cities can be thought of as systems that can be influenced via policy, and urban settings are opportunities to promote health and environmental sustainability. And yet, major drivers of differences in health across and within cities, I would argue, remain underexplored. Cities are doing things, they do many things, often for reasons unrelated to health, most often for reasons completely unrelated to health, and yet rigorous evaluation of the impacts of these things on health and health equity are lacking, and that health and environmental co-benefits, as we've talked about, are critical, and people have, there's a growing discussion of these links, for example, through the planetary health movement in particular, but there's relatively little empirical documentation of this. So this brings me to the DIEZ-ROUX study, which I want to share with you. This is quite an ambitious study that we are engaged in. It's funded by the Wellcome Trust. And it's the goals of this study are 3. 1, to create the evidence base needed to make Latin American cities and other cities, because we hope what we learn in Latin American cities will have some universal value, make cities healthier, more equitable, and environmentally sustainable. Engage policymakers and the public in a new dialogue about urban health and urban sustainability and implications for societal action. And create a platform and a network that will ensure continued learning and translation. And I'll tell you a little bit more about this. So these are 3 interrelated goals. The first one is a traditional scientific goal. The second goal is an outreach goal, which is very important. And the third role is more of an infrastructure development capacity building goal, which is also equally important, particularly because we are working in a region which traditionally has not had as much investment in creating infrastructure and capacity building for research and policy translation. So this core elements of our approach will not be a surprise given what I've said before, but really we think it's a multi-level approach. We try to be integrative, encompassing different domains, a multi-method, as you'll see, a systems perspective, and engaging policy actors as much as possible throughout the process. We have an absolutely terrific team that you see listed here, including many countries in Latin America and also institutions in the United States. The study is coordinated by the Urban Health Collaborative at Drexel University, and you can see the list of our partners. We also partner with the Pan American Health Organization. So it's a really wonderful team. The study has 4 aims. The first aim is to identify city and neighborhood drivers of health and health inequalities among and within cities. The second aim is a policy evaluation aim to evaluate health, environmental, and equity impacts of policies and interventions. The third aim is to employ systems thinking and simulation models to evaluate urban health environment links and plausible policy impacts. And the fourth aim is to engage the scientific community and the public and policymakers in particular to disseminate and translate findings and hopefully generate lessons for Latin America about what makes cities healthier, equitable, and environmentally sustainable. I want to briefly tell you a little bit about each of the aims, just very briefly. This is the first aim. We have identified the universe of cities, so all cities with 100,000 people or more in the countries in which the study is working, which is a significant proportion of the population of Latin America. You can see variations in the city sizes for the different countries. It has been quite a task to operationalize what we mean by city. And in fact, we have many different definitions of cities. We have structured the data into what we call level 1, which is the sort of city or / urban agglomeration level. And as you can see, we have 3 different definitions. Level 2, which is sub-city units, often counties or municipalities. And level 3 is neighborhoods within those units. So this is described extensively in a paper in, sorry, I don't have it cited here, Quitzberg et al. In the Journal of Urban Health. So quite a bit of work to operationalize this structure to which we can then link a range of environmental and health metrics. And this gives us a lot of flexibility to work with data that's available, as I'll mention in a few minutes. So we've created a comprehensive data resource that has variables at each level. So at the city level, also at the sub-city level, and you can see some of I'll show you some examples, but you see it's quite a broad net that we're casting in terms of the kinds of things that we want to characterize about cities, about neighborhoods within cities, and health outcomes. Here we depend for this first aim on existing data. So this is really a big secondary data analysis effort, linking vital statistics data, existing survey data, hospital discharge data, and when available, there's some cohort data that can be linked as well. And so through geocoding and data linkages and a variety of analytical approaches, we're using this to answer a number of questions about how city characteristics relate to health, both cross-sectionally and also longitudinally. And I'll show you, give you a preliminary taste of some of the data. This is where we're in the process of finishing up sort of the first phase of the harmonization. So we're starting to put out mostly descriptive analyses, cross-sectional analyses, and longitudinal analyses are forthcoming. So the first thing that I just wanted to share with you is that we are seeing large heterogeneities in built and social environments across cities. So these figures show the cities are clustered by city size, and they show different variables. So population growth, population density, fragmentation, which is a measure of the fragmentation of the built up area of the city, and a travel delay index, which is a measure of traffic congestion. So I just want to highlight here how there's enormous differences across cities in these variables. And this is really important because it raises really important questions about why those differences exist, what policies are related to these differences, and also what impact might these differences have on health. A team within the project led by Olga Lucia Sarmiento has done very interesting analyses clustering these urban landscape and street design features in order to develop profiles or typologies of how cities what cities look like from the point of view of urban landscape and street design. And we are in the process of analyzing how these features, which are amenable to policy, relate to a range of health and environmental outcomes. As you might imagine, social environment features also differ dramatically across the cities. This is an example based on a PCA analysis of a variety of census-derived indicators. Again, large differences across cities. Here, each of the box plots represents a countries, and you can see that certainly there are differences across countries in these indices of living conditions, education, and service provision, but there are also large differences between cities within countries. There are also large heterogeneities heterogeneities in health between and within cities. This is an example of life expectancy. I mean, this is unique data. This has never been done before to estimate life expectancy for all these different cities. This quite major undertaking led by Usama Bilal, and taking into account the complexities of working with vital statistics data, and which we can read more about. It quite a task. But what this shows is that there are also, although there are life expectancy differences across countries, as you can see on the bottom for the different countries, there are also very large differences in life expectancy within across cities within a country. The causes of death also differ across cities. This figure shows each of the lines, each little line, vertical line, represents a city. And in this case, and the figure shows proportionate mortality by cause. And the causes are at the bottom. In this case, they are sorted by communicable, maternal, and neonatal and nutritional deaths, which is the pink at the top. So you can see that there's a very broad range in the percent of deaths that are due to communicable, maternal, and neonatal and nutritional causes, 5 to 50%, depending on the city. Large heterogeneities in violent injuries, proportionate mortality from violent injuries across cities. Large heterogeneity in NCDs across cities. Why? What factors are related to these differences in life expectancy and these differences in causes of death? And we suspect that city environmental factors have a lot to do with this, and this is what we're currently exploring in subsequent analyses. Of course, as I showed you before with data from the US, large differences within cities and life expectancy. This is a first look at some within city differences in two cities, Santiago and Buenos Aires, looking at sub-city units, which are relatively large units. We're doing work now with finer geocoding to look at smaller neighborhoods, but large differences within cities as well. We're also finding that policy relevant city features are related to environmental and health outcomes. And this is preliminary data. This is looking at PM 2.5 levels across cities. On the left, you can see that there's, again, quite a bit of heterogeneity across cities, but also many cities and many sub-city areas are above standards, above the PM standard in the region, which has been demonstrated before, but this is more, encompasses a larger number of cities and also sub-city areas. And we're finding that certain city factors are related to PM 2.5. Now, this may not be a surprise, and the intent of this is not to do sophisticated modeling of predictors of PM, but rather just to show in a descriptive way what city factors that are amenable to policy are related to PM levels. This is incredibly powerful, yet simple, yet powerful information for cities. Things like the presence of mass transit infrastructure is related to lower levels. Population density is related to lower levels. Intersection density, probably related to traffic, is related to higher levels, for example. So this really gives policymakers some ideas about the things that they might want to focus on. Of course, we will be doing additional evaluations of change versus change analyses of these data, but nevertheless, even though these are cross-sectional descriptive data, they're incredibly powerful and very novel for lower and middle income countries to have this kind of data compiled and described in this way. City features are also related to health. Traffic mortality. This is work by Alex Quitzberg. Should have mentioned the prior work was by Nelson Gouveia, showing that city features like population density, higher population density, less traffic-related mortality, a better social environment index, less traffic-related mortality. A measure of fragmentation is related to higher traffic-related mortality, higher intersection density, probably because traffic is going slower, less traffic-related mortality, presence of mass transit, less traffic-related mortality. So again, indications that city features are related to health outcomes. This is hot off the press. This is the beginning of some change versus change analyses that we're doing. This is looking at percent differences in infant mortality rates, looking at a time series of cities with PM 2.5 levels. So we have time varying predictors and time invariant predictors. And what we see here is that increases in PM 2.5 are related to, these are fixed effect models, are related to increases in infant mortality rates. So both the average PM 2.5 for the city cross-sectionally is related to higher infant mortality, but also the within city increase is related in PM 2.5 is related to a within city increase in infant mortality. So this is where we're continuing to develop these analyses. There are many other studies in progress that, but I hope to share with you at a future date, looking at a variety of other environmental factors. I also want to highlight that we're also looking at co-benefits, so really trying to characterize simultaneously, for example, whether some of these city profiles are related to simultaneously to health and environmental outcomes. Ione Valencia, who's a postdoc with us, is leading some of that work. The second aim, very briefly, is to evaluate health, environmental, and equity impacts of policies and interventions. We've identified 4 thematic areas for policy that are listed here because they are important in the region. And we have funded a number of policy evaluation projects. I don't have time to get into details, but you can see them here on the slide. I just want to highlight one of them, which is the Transmicable evaluation in Bogota, led by Olga Lucia Sarmiento and her team at Universidad de los Andes in Bogota. This is a wonderful project that is evaluating the health and environmental impacts of a new transportation system, the Transmicable. This is a before and after controlled study with very detailed data collection using a variety of approaches, surveys, air pollution monitoring, systematic observation, travel diary, accelerometers, etc. And their data is starting to come out soon, and they're looking really at the impact of this intervention on health and environmental outcomes, and using this natural experiment with you know, an intervention and a control site. So this is, I think, an example of some of the work that can be done, that needs to be done. The third aim is to employ systems thinking and simulation models. We're focusing on two areas for systems approaches: transportation policy and food policy, because these are areas that are characterized by feedbacks, dependencies, and where there's a tight health environment link. And because of their relevance and also our team expertise. And we're basically doing we're using 2 approaches. One is participatory systems approach, which is a more qualitative, stakeholder engaged systems approach, group model building, where we bring together stakeholders to think about the impact of transportation and food systems on health. And they jointly, using their knowledge from various fields, these are academics, but also policymakers, nonprofits, community representatives, they develop causal loop diagrams that make explicit some of the things that they think are going on. And this is a very interesting exercise. In the process, they learn about the tools of systems thinking, about these reinforcing and balancing loops. They identify these yellow dots, potential areas for intervention. So it's a very rich exercise that can be used to generate collectively these systems causal loop diagrams. You can see there's a paper on this by Brent Langelier that describes the process and the outcomes. And then this is one of the inputs, among others, that goes into the development of actual agent-based models. So there's we have 2 models under development, one focused on transportation behavior and its impacts on environmental and health outcomes, and another focused on factors, policy levers for influencing ultra-processed food purchasing. So I hope to report on that in the future. So really, as you can see, we're really trying to bring together the different types of evidence for urban health: observation in aim 1, experiments in aim 2, evaluation of action, natural experiments, and in aim 3, systems modeling. And quickly, the 4th aim, which is really important, is about dissemination and policymaker engagement. And here we really want to promote, as I said earlier, a new way of thinking about what drives urban health that's beyond medical care, because even though we're very used to talking about factors beyond medical care in the public health world, this is not as true out there in the world. There's still a tendency to default to medical care as the main driver. So we want to change the dialogue about that. Engage various stakeholders in research and evaluation, disseminate, and advocate as well. And so we do this through a variety of events, something we call the Knowledge to Policy Forum, various events with policy stakeholders in the region, in our meetings. Of course, now this has moved all to virtual, to get input from the very beginning of the study into what we're looking at, what data we're using, what questions we're asking, when we get results, what do they mean, and what additional things should we be doing. We also develop policy briefs in English, Spanish, and Portuguese, and we do extensive digital dissemination as well, and media outreach. So for example, some of the analysis that I showed you on within city differences in life expectancy, something that's well known in higher income countries but had not been done, for example, in Latin America, got significant press coverage in the region and generated a lot of interest. So the study really has highlighted some of the challenges and opportunities in doing this kind of work. First of all, I think it really requires a major investment in creating flexible definitions and data structures, because the data is very imperfect. It's not, the perfect research data that we're used to in these rich cohort studies, but it's data from which meaning can be extracted. And as we use it and identify some of the problems with it, it generates the need, the urgency to improve the data and collect new data. And so this is really important. Heterogeneity in the data availability. So yes, there are challenges, but that's sort of our challenge, to really learn something, what we can from the data that we have, and figure out what additional data we need to collect to make our inferences more robust. Very important investment in capacity building and creating a collaborative platform. We have in our regular team meetings, we have over 60, 70 participants regularly across, people with more and less experience, old data and new data. So certainly, vital statistics data we can still learn a lot from. Also opportunities for new data collection, like what Olga Lucia's team is doing, and other things that we're exploring, for example, through Google Street View. Gina Lavasi and her team have been doing quite a bit of that. So new data that can be brought in and linked. Really, there's an untapped potential for city comparative analyses, I think, not just in Latin America, but also in the United States and other countries. And there's great interest in the policy community in this type of work. So a lot more to do here. I would be remiss if I did not talk a little bit before closing on COVID-19. So of course, COVID-19 has really forced us to think about COVID-19 and the environment. And I think it has been very interesting to see how there's an incredible opportunity, and we've seen this emerge in work that's already been done, reconnecting infectious diseases to the environment. I mean, infectious diseases are strongly driven by the environment. A lot of work on environmental health is focused on chronic diseases, but certainly we have seen now with COVID how we have to see infectious diseases in the context of environmental factors as well. 3 examples: crowding, the impact of transportation, air pollution interactions with COVID, for example. The links between environmentally influenced chronic diseases and infectious diseases. We know that chronic diseases increase the severity of COVID. So here's also another example of how the environment affects infectious diseases. And there are these environmental inequities that are drivers of both chronic and infectious disease inequities. So I think it's an incredible opportunity for the environmental health community to also broaden its thinking, to think about infectious diseases in ways that perhaps are that recover some of the history of environmental work on infectious diseases and integrate them with chronic diseases. And perhaps there's also a silver lining. We have seen, for example, incredible changes in our cities as a result of COVID. Cities without cars, what do they look like? What are the impacts? I know many of you are actively involved in thinking about that and perhaps evaluating some of the impacts of that. So there's also an opportunity to see incredible, natural experiments of what happens when we change some of these, when we take drastic collective action that results in major environmental changes. What does that mean for health, aside from COVID, and for the environment? So to conclude, urban environments, I think, are the environments of the future, and I think they probably will be despite COVID. We hear a lot about, will cities still be around? Will everyone move out of cities? Cities will continue, I think, to have a lot to offer to humanity And I suspect that urban environments will continue to be important. The question now is, how can we structure? What can we learn from COVID so that we structure urban environments so that they are health promoting in terms of infectious diseases, but also in terms of other diseases. The environment writ large, I can't emphasize this enough. Of course, traditional environmental exposures are really important, but thinking more broadly about other environmental factors, how they interact, how they come together in systems. Opportunities for interdisciplinary and policy-oriented environmental health research, I think, is really critical and an opportunity for urban health. Multi-methods, as I illustrated, from description, let's not forget the power of a great description, to simulation, and health and environmental sustainability as two things that are really entwined, and we need to think about them and study them, I think, in that way. And last but not least, the environment as key to health equity. And this is another, I think, opportunity for environmental health research to reemphasize its equity focus. And so I'll stop there. Thank you very much. It's been a pleasure to share these thoughts with you. I'm sorry that we cannot interact in person. Thank you.